Hey everybody, it's David with Jeffrey Roche. We have our own podcast today. We're coming to you live from HLTH in Las Vegas. We thought we'd share with you a little bit about what we've learned since being here, give you an inside view on the event, some of the sessions that we've participated in. And if you haven't had a chance to be here, maybe we can educate you, engage you, maybe even inspire you on some of the conversations that are going on in Las Vegas this week. I host the Highway to Health podcast on MarketScale. You want to plug for yours?
Sure. Yeah, I co-host the Holistic Leadership, Future of Work in Education and Healthcare podcast on MarketScale.
I wasn't here on day one, but you were. And I think some of the main takeaways that I have from today tie in to some of your experiences yesterday. You know, some of the conversations that I've had most recently, whether it's on a podcast or just on a conversation, is around value-based care, which isn't a new topic. I've been in healthcare the last 12 years. We've talked about it every year that I've been here. But there's been some nuances and some further education, some progress, for lack of a better word, that's being attributed to some of the new innovations that we've seen in healthcare, and honestly, some of the more collaborative partnerships that we're seeing. You know, today I sat in a session where it was executives from DaVita, Biogen, Maven, and Geisinger. These are the leaders in value-based care. Not self-proclaimed, but the consensus is. And I was pretty, shocked's not the right word, because healthcare, it takes a while to see true adoption or absorption of new models and new technologies. But I was surprised to hear the number of patients, the number of dollars that are attributed to value-based care models across these organizations. And I'll just start with one. I'd like to get your feedback. So DaVita, large company. Maven, large company. 17 million lives. 145 countries. Only 10% of the lives that Maven touches are a part of a value-based care model. DaVita, only a third. Of those 33% of DaVita, it's 100% full risk model, which I thought was interesting. So we'll talk through some of these things. Geisinger, leader in the industry. You know the history there. About 50-50 fee-for-service value-based care models, which to me, a little lower than expected. You have some history here. You've got some background. There's some challenges that go to this that are well-reasoned, legitimate challenges. This ties into a lot of the things that you talked about yesterday and learned yesterday. Speak a little bit about your experience yesterday in day one.
So, yesterday I had the privilege to attend the CareQuest Institute for Oral Health event that was entirely on, really addressing systemic innovation. And the idea was really about how do you integrate oral health within our primary care setting and really get at value-based care. And if you think about it, oral health is such an important aspect of the whole person and the whole person care. Yet in the United States, we still don't treat it as that. And it's really interesting. I mean, if you look at the statistics, so many diseases could be detected through really, really good oral care. And if you think about it from a value-based care end, so much of our healthcare system could be a more equitable system, could be a more supportive system, really could be a more human-centered system if we integrated oral health. And I want to, obviously applaud Maria Filipova and her team there for really not just raising attention to this, but doing so with a real attention to bringing payers. They had payers there, they had physicians there that also represented, the multiple sides. And I think, that payer piece is critical. I mean, because to your point, Geisinger, which obviously, is a 50-50 with value-based care and fee-for-service. I mean, if you look at why that is, they have their own health insurance plan. And they've had their own health insurance plan for quite some time. And so healthcare systems that have their own health insurance plan are in a stronger position to really leverage or move more towards value-based care. But I think as we move towards value-based care, and I honestly find it interesting that we haven't already, other than the fact that we're so risk-averse in healthcare and we have a lot of people who kind of don't row in the same direction, we have to remember oral health. And that was a central message, certainly, that Maria and her team shared. But the other piece of it, too, that was shared was we've got to invest more in oral health. We've got some phenomenal startups. They showcased some of their startups yesterday. Truly trailblazing work. I was inspired by some of them. There was a startup there that actually had a technology that they built that you can put into your tooth, and that tooth can measure the acidity of things you're eating or drinking. And they have scientific evidence behind it to show you the impact that could have to diabetes, the impact it could have to heart disease. So, I mean, really, really innovative work. But if you have less than 1% of the investment dollars going to oral health, we're not going to be able to really drive the needle there. And I think CareQuest is certainly on an important mission, a mission that should be recognized and a mission that should be joined in. We're going to really move towards, not just value-based care, but a better healthcare system for all.
Yeah, and I would imagine, I wasn't a part of that session, but I would imagine a large percentage of that 1% is made up of cosmetic or aesthetic investment.
Yeah.
I think of Align and other direct-to-consumer technologies that have become available in the oral space. My dad, 28 years in the military, a dentist in the military for that long, and he would completely agree. He oftentimes was the first one to know of a health condition from a patient, including dietary disorders like bulimia and others. The signs are obvious to the educated and to the one that, to that dentist. I've heard about it for a long time through his voice, and I can imagine there's a lot to be learned from the oral health of our patients. And that kind of goes back to, that builds on the conversation that I had that was titled, "What are we willing to risk to be well?" with these executives talking about value-based care, is it went down to they talked about the challenges of attribution, where in value-based care you have more players responsible for the overall health of the patient, but who's the primary and how do the payments get split up? And there's risk there when DaVita, Maven, these, the dentists the oral health care all have a hand on the patient, when that bundled payment or that value-based care reimbursement model gets delivered, how does the pie get split up? There's science to that. There's areas of gray to that I think adds to the risk that these providers, these patients, everybody involved are hesitant to adopt.
To your point, I think it's that it is truly that issue. I mean, right? Like, I mean, as a, when I was a hospital administrator, we were working, and obviously, this was 2009 through 2008 through 2017. And if you think about it, during some of those years, we were doing some shared services type programs through CMS. In fact, they were doing through CMLI, the Centers of Medicare and Medicaid Innovation. They were doing some projects just like leading to a value-based care model. And part of the challenge with them was getting providers on the full ecosystem to accept what they would get out of it. But ultimately, when you really think about it, the system has to move. Fee-for-service is not sustainable. We see that. We've got healthcare systems crumbling every day. We have hospitals closing every day. We have really significant shortages in all aspects of our healthcare system. We have doctors that are leaving. We've got nurse practitioners that are leaving. And so we've got to move more quickly to value-based care, because value-based care is going to also help, in many ways, can help address some of these issues too. I think to your point on who owns the patient, I mean, I think at the end of the day, the physician, the attending physician or attending provider, if it's a nurse practitioner or a physician assistant, I mean, obviously, depending on the state, there's some other regulations we have to consider there. But ultimately, that provider, that clinician, does still own the kind of responsibility for and with that patient. I think it's time for the full ecosystem to realize, I mean, if you're a DaVita, if you're a Geisinger, if you're another provider in the ecosystem, there's got to be some way of us assigning appropriate percentage of what we should earn in the process. And government's going to do it if they can't figure it out at some point. And I think, government has made more moves, more steps towards this, and I think we're going to continue to see that happen.
When you say government, what do you mean?
I mean, I think at the CMS level, I mean, at least for the Medicare and Medicaid services portion, obviously the commercial side still remains, a little bit of a piece. But I mean, let's be honest, right? I mean, if you think about it, in most communities, Medicare could be a 50% market share, Medicaid could be a 30% market share, and then the rest is commercial. And so Medicare and Medicaid still make up the bulk of these things in most communities. And so I think for commercial, I think it's way past time for our providers and our payers to just figure this out. We've been talking about value-based care now since, at least that I can remember, 2008, 2009. And we're sitting in 2023. And frankly, in my opinion, we've seen little progress. A little bit, but every little bit seems like we go back. We don't really take steps forward.
For me and for our listeners, and if I'm putting you on the spot, I apologize. What is the difference between value-based care compared to bundled payments and compared to what used to be termed, an ACO?
The best way to view that is bundled payments and accountable care organizations would be kind of a piece of the puzzle within value-based care, right? It's really that idea that I think even under a value-based care full system, I don't, in my opinion, based on what I understand, you wouldn't necessarily get away with even ACOs. You still are going to have shared savings programs because ultimately, even in value-based care, you're going to have, different pilots or different innovation type projects related to orthopedics, for example, which oftentimes has been one that a lot of us are familiar with, because if we can do a really good job to take care of a patient, do a surgery, get them home, get them into rehab, keep them home, not have them readmitted, then we're getting to shared services, or shared savings, but we're also getting to value-based care in that model, right? So in many ways, it's all combined, and I would also add population health, certainly an important piece to that. ACOs play an important role in population health, and I would also add, really advancing health equity. I would never want anyone to look at and say like an ACO or shared savings as not part of value-based care. They are really a part of the full spectrum of value-based care.
When I think of what value-based care could mean or what it could be long-term in its idyllic form, if I'm a physician and it gets to that ideal state, you could argue it would empower me to provide the kind of care that I got into healthcare to provide. This holistic vision, providing the best level of care to the patient community, which is intriguing, it's inspiring. But we've already talked about the risk and what might be holding some of them, some of us back. Let's talk about the impact to the patient too. If we're working in a value-based care world, it makes it even more important for the patient to know which providers are performing at a higher level, because it takes a lot of work on that provider, a lot of collaboration to provide that value-based care, that type of care that we're all hoping for. There's got to be some innovation there. There's got to be some improvements there to get the patient educated enough to make the right decisions on where they go and how they go about their care journey. And that goes into the consumerism topic. What have you seen in that space that might inspire you that this is possible, and we can empower the patients to be really engaged and informed and educated on the kind of services that are available?
Well, I mean, we've definitely seen a push, right? I mean, you look at, and obviously there's a big debate. There's a lot of frustration in the healthcare world on this, but, the work of health grades, the work of Leapfrog, the work of all these different consumer-based ways of measuring care, measuring performance is an important step towards that. And again, there's always going to be debate on rankings. But when you really think about it, in our society, at least in the United States, we have more access to research and understand all the aspects of purchasing a car as a consumer than we do a provider or a hospital or health system. And we don't make it easy. And so I think as a whole, CMS and others have made some really, really important strides toward this. I mean, Hospital Compare certainly is an important step to understand readmissions and understand quality, and then you have health grades and you've got Leapfrog and, kind of third-party approaches to this. Ultimately, we've got to improve in these areas, and we've got to be more transparent. In our system of healthcare today, there's this idea in many cases that the bigger the health system is, the more superior the care will be. But the irony is that if you actually compare it, that's not always the case. Sometimes our smaller hospitals, our smaller healthcare systems, who are really making value and impact more of a priority, have a higher quality. In fact, I had the privilege of running into a chief medical executive that I worked with today here at Health, that I worked with for a decade. And we were reminiscing about the fact that our little regional community healthcare system had higher quality, had higher patient and staff engagement scores than the system that acquired us still to this day. And unfortunately, our system scores have plummeted under this new system. And, we were just reminiscing on that. And I asked him, I said, as we were talking, I said, what's the difference? What changed? And he said, the focus is not there in the same way that we had it. And so, when I think about it for the patient, a patient today expects that things are going to be managed. The whole person care is going to be managed. And this is why we're seeing disruptors. This is why we're seeing startups. And this is why we're going to continue to see it, because the current traditional model of healthcare is not managing the whole person care. And we're not managing it with our patients' needs in mind, and we're really managing it still with our providers' needs in mind. I mean, I'm not speaking about our docs and our nurse practitioners. I'm really talking about the system.
Right.
And so I don't know how far we have to go until we really realize this from a systemic level, but it's time we've got to change. And I think the disruptors are going to force it.
Yeah, and I think the disruptors are starting to focus a lot more on, you talked about health equity. A version of that is health literacy, because you can go to the patients with the information. But this isn't buying a car or buying a plane ticket. It's highly clinical information and data. And there's different levels of literacy when it comes to understanding that kind of information. What I've seen recently and through some of the conversations that we're having is the understanding that we've got to bridge the gap and get not only our patients access to care, but we have to help them understand what some of this means, because the literacy is at all different ends of the spectrum.
And to your point on that, right? I attended a session today, two different sessions. One that was actually, you were there too with YouTube, right? And I also attended another one with LinkedIn, which was all about, how can you use your voice and your expertise to impact the audience? The reality of it is if you look at medicine, if you look at healthcare, there's a lot of work occurring in that space. I mean, if you think about just the sheer fact of physicians, so many physicians are turning to a YouTube or turning to other sources to share information. And the irony about that is that even physicians using TikTok, I mean, Dr. Austin Chang shared an example where, he shared, a new elective procedure in endoscopy in a TikTok video that ultimately then patients from that video went and actually sought out doctors to have that elective procedure done. And those doctors then called him and said, "Oh, Dr. Chang, they said you referred us." And so, things have changed.
Yeah.
I think, from that perspective alone, that's not something we would have ever thought would be the case.
Right.
And so, I think we just have to be prepared for it.
Yeah, I think, influencers like the ones you mentioned that are delivering this education through new forms of media, powerful. Just in my own experience, AI is going to be a big part of this too, because I used to Google everything that I didn't understand. Now I chat GPT everything I don't understand. And I've got a prompt that I just copy and paste. Explain this to me like I'm a fifth grader in West Texas. It does a pretty good job. And I'm starting to reverse engineer some of these new innovations, new technologies, but also new types of treatment and all different types of therapies, because AI is bridging that gap for me and improving my health literacy, even though I've been in this industry for 12 years. And that opportunity is there for everybody now.
And I think to your point, what's critical is you got to harness it, right?
Yeah.
If you think about what ChatGPT and artificial intelligence can represent, it can be a great way for us to help with efficiencies. It can also be a great way to help our staff take away tasks that take away the time that they need to be with patients. There's so much encouraging signs from those ends. This is not about replacing physicians, but this is really about how do we create more technology or more technological solutions that ultimately can help our staff and help our providers and our clinicians. And so I was at another session earlier where they talked about that. And I think from a workforce perspective, which is a number one issue at every healthcare system today, workforce.
Amen.
Probably a number one issue at a DaVita, probably a number one issue at every aligned provider, maybe other than maybe a virtual care type of offering. You've got to be thinking about what we do to augment challenging, aspects within the workplace that make it harder for our team to do their job. That's what our focus has to be.
That's day 2 in a nutshell. I can't wait for day 3.
Yeah, me too. It's exciting.
Don't party too hard tonight, because we got a long day tomorrow.
Yeah, I don't party. Come on, David. I'm an angel. There's no partying at Health, right?
That's right. Not even in Vegas. Thanks, Jeffrey.
Thank you. Appreciate it.